Thanks, Sandy. Firstly, I'd just like to check if my Diaverum colleagues are here.
Yay!
And they're not at the bar at 5 o'clock in the afternoon, so I think most of them are here. Thank you. Secondly, I'd just like to say there are a few images in my presentation that do show deceased patients, so I hope I don't offend anybody.
My name is Catherine Fleming and welcome to Nephron News. Breaking news today, a Sydney man was found dead on his bathroom floor. The 42-year-old father of 5 reportedly bled to death from his arteriovenous fistula. The fistula is required for his hemodialysis. The man suffered from end-stage renal failure for 6 years, and ironically, his vascular access that acted as his lifeline was the very thing that killed him. His distraught wife discovered the body and said the bathroom resembled a bloody massacre. The cleaning company contracted with the cleaner said they received 4 to 5 calls of this each year and wished it wasn't so. Medical experts state that fatal vascular access hemorrhage is potentially avoidable and deserves urgent scrutiny. Police do not believe his death was suspicious. Julie Tondello of Diaverum, Diamond Valley Clinic, is here to give you the invested in get the loop.
Some of you might recognise our news presenter. Today I'd like to talk to you about fatal vascular access hemorrhage, or FVAH. It is a relatively rare complication of haemodialysis. However, as the acronym suggests, it can be fatal. In the past, not a great deal has been written about this topic, though this is slowly changing. As our news presenter stated, fistula ruptures are potentially avoidable and deserve further scrutiny. Many of you will be familiar with a dialysis blog called Big D and Me. In February 2010, a 15-year-old girl from New Zealand named Maya posted this story on the Big D and Me blog. She talked about how her father saw and swollen fistula burst when in bed at home and he bled to death. Over the following 18 months, subsequent blogs on the Big D and Me post showed that his death is depressingly common. FVAH was starting to look a lot less rare. Many of these deaths may have been prevented if haemodialysis nursing staff and the patients themselves knew of the possibility of their fistula rupturing and were able to identify the risk factors and how to respond should this devastating emergency situation occur. At Diaverum, Diamond Valley Dialysis Unit, we decided it was time to get the word out about FVAH. What could we do about this? So my objectives today are to define FVAH and its prevalence in Australia, New Zealand and the USA. Locally at Diamond Valley Dialysis Unit, we asked the question, could your fistula rupture? We wanted to establish the level of knowledge of our patients and of our nursing staff in relation to fistula health and fistula ruptures. We wanted to develop a training program on fistula health training for patients and staff, and of course we wanted to test the result. So what's the definition of fatal vascular access hemorrhage? Kidney Buzz states that FVAH is severe bleeding from a vascular access point, most commonly fistula grafts of a dialysis patient. It's a potentially fatal emergency situation and requires immediate action. I just want to talk very quickly about blood flow, and as most of you know, the blood loss occurs much faster from an artery. This information was taken from the Forensic Science Medical Journal, which I read a lot of in the last couple of months. It's a bit sad. So the normal blood flow in a brachial artery is about approximately 85 to 110 mils per minute. Once a fistula is created, the blood flow increases to about 400 to 500 mils per minute. And within only 1 month, it can be anywhere up to 700 to 1,000 mils per minute. The brachiocephalic fistula has a greater flow than the radiocephalic fistula. And the femoral artery, if you rupture from your femoral artery, you will be unconscious within 1 minute and dead within several minutes. This photo shows the body of a 45-year-old woman. She was found dead on the floor in her bathroom with a trail of blood leading from this room to her kitchen. Her autopsy result shows that she had a left upper leg arteriovenous catheter linking the femoral artery to her femoral vein. The catheter had been cut. Death was due to exsanguination, and the manner of her very quick death was suicide. So what's the prevalence of FVAH? And it seems that no one actually knows for sure, and that they are more common than most imagined. As mentioned earlier, FVAH is a rare occurrence. It accounts for less than 1% of deaths of hemodialysis patients. So let's have a look at the prevalence in Australia and New Zealand. According to ANZ data in 1965 to 2014, there were 26,278 patients hemodialysing in Australia and New Zealand. 97 of these died as a result of FVAH. According to a study in the States, between the years of 2000 and 2006, which is the most recent national data available, there was 1,654 fatal vascular access hemorrhages. These are only reported deaths and are considered to be an underestimate. Another US study showed that 78% of hemorrhages occurred at home. And while FVAH is not tracked separately in most other countries, the Big DME blog finds out about 5 to 10 per year from shocked relatives looking for answers, and this is no means a definitive list. Posts come from all around the world. The numbers vary between countries, health systems, and even units. There does not seem to be a trend, and it seems to depend on the quality of the unit that you're working in or dialysing in. In a well-managed unit, fistula and graft hemorrhages are rare. So we decided to hold a staff meeting at Diamond Valley Dialysis Unit, and now that we're aware of the prevalence of FVAH around the world, we wanted to avoid any of our patients becoming a statistic of FVAH. How could we raise awareness? We needed to prove a need for education and training, and we then needed to develop the training and conduct that training. All easier said than done. We also included our North Melbourne dialysis clinic. To gain an understanding of the level of FVAH knowledge of patients and staff, we conducted a quality survey called our Fistula Health Education Survey, and we did one specifically for patients. The knowledge of patients was virtually unknown. Many patients had limited knowledge about fistula ruptures, and like this patient, he answered no idea to most questions, which was most concerning. The knowledge of staff was a little bit more promising, but still required further and ongoing education. So our patient results were a little bit disappointing, and as professionals we had some work to do. The orange columns are correct and the pink answers are incorrect. We had 68 surveys completed by hemodialysis patients, and the first pink column shows that 70% of patients didn't even know that their fistula could rupture. About 50% didn't recognise the warning signs of a fistula rupturing, but the third column shows about 78% of patients said that they would report any warning signs to their dialysis nurse. But I'm not quite sure how accurate that result is, considering they didn't know what the warning signs were in the first place. 6% of them said they would do nothing at all if they did see some warning signs in their fistula. 8% said, oh, I'll make an appointment with my GP. And 7% said they didn't know what they would do. And about 60% of our patients really didn't know exactly what to do if their fistula did rupture. Thankfully, the staff results were a little bit more pleasing. However, a bit more education is still required. 22 surveys were completed by hemodialysis nursing staff. 80% of them said that they assessed the condition of a fistula before every hemodialysis treatment. 80% said that they knew a fistula could rupture. 90% said they knew the symptoms of a fistula that was in danger of rupturing. And 70% knew exactly what to do if a fistula did rupture. So a little bit concerning. So my key messages today, we wanted our fistula health training program to deliver 3 key messages for both patients and staff. The first one, fistula ruptures can happen and they can be fatal. Number 2, be fistula fussy. How to avoid fistula ruptures. And 3, what to do if your fistula does rupture. We wanted our patients to be fistula fussy. Our fistula health training program included ways patients could avoid a fistula rupture and what warning signs they needed to be aware of. I won't elaborate here as we cover the warning signs from a nurse's perspective in a moment. We also advise patients of the actions if they do suspect something is wrong with their fistula. And one action is to avoid trauma. This lady got her arm caught in an overhead fan while she was dancing on a bed in far north Queensland. Thankfully, she didn't have a fistula, as this could have been fatal. As health professionals, we can minimise potential ruptures by identifying risk factors during vascular access assessment. There's some really good articles that have been written, and one in particular by the name of Linda Ball, and this was in the Nephrology Nursing Journal in 2013, Fatal Vascular Access, Reducing the Odds. And she talks a lot about access-related risk factors that we need to be aware of. And they are infection, sepsis, stenosis, aneurysm, and pseudoaneurysms. And these are some other risk factors and warning signs of potential ruptures that I'm sure you're all aware of. Here are some visual warning signs of potential ruptures, and these were taken from Nephrology Nursing Journal in 2013. The first photo shows a complete erosion of a buttonhole tunnel due to only a 3-day-old infection. The second photo, you can notice the colour difference between the aneurysm area in relation to the surrounding skin. The third photo, you can notice where the pigment is separating as the aneurysm enlarges and the skin becomes thinner. And the fourth photo, again, was taken from the Forensic Science Medical Pathology Journal in 2007. This man was admitted to the hospital the day before his death. He had surgery on his ulcerated AVF. He was discharged, and day 2 post-op, he started to bleed again through the bandage around his arm. He collapsed and died in his bathroom. Death was due to exsanguination, and I guess the main purpose of me putting this photo in, it demonstrates the importance of us being even more vigilant on assessing accesses post-procedures, post-surgical procedures. So what are some of the ways that staff can avoid a fistula rupture? Vascular access monitoring before every dialysis treatment, including fistulas of patients who self-needle themselves. We have probably 4 or 5 patients at our clinic that cannulate themselves, and quite often they'll say, yep, I'm ready, and we just connect them up. And we don't even have a look at their fistula, but we really need to change those practices. We need to look, feel and listen, and we need to make sure that early detection of failure will allow timely referral of patients for intervention. We need to report any risk factors to your unit manager or designate immediately, and refer on to nephrologist, vascular surgeon or vascular access nurse if you have available. We quite often take photos of our patients' fistulas with their permission, obviously, just to keep track of what's happening. And obviously be scrupulous with hygiene, dress and sterilise any cuts or scrapes near your fistula. Document in patient files, something we're not often good at, and handing over to staff about vascular accesses. Avoid puncture area and poor site rotation. The Kidney Disease Outcomes Quality Initiative that was recently updated in 2015 states that because of the high volume of needle insertions, the site selection for each cannulation is paramount in the preservation of vascular access and the avoidance of rupture. Correct site rotation within the cannulation zone should cause the entire fistula to dilate as evenly as possible. And this first photo shows an AVF with 2 areas of one-sititis. And this can potentially cause aneurysm or stenosis. The second photo shows a graft with a possible pseudoaneurysm, and it's due to the lack of proper needle site rotation. And you can see the graft material here is so damaged that it would be difficult to repair itself. And this really just highlights that regular cannulation training and discussion to ensure that the current guidelines and recommendations and policies and procedures are always observed and followed. It is important that nursing staff are able to safely determine sites for cannulation, and this topic deserves a lot more time and detailed education, but the current guidelines is a great resource to go to for this. So what do we do if a rupture happens? We don't panic. That's the first thing. Press with your finger. Lift your arm and call for help. So as you can imagine, excessive bleeding from a ruptured fistula would cause great anxiety and alarm, and it requires immediate action to save a life. Massive blood loss and death will occur if quick action is not taken. We advise patients to learn what to do and to make sure the people they spend the most time with also know what to do. And we feel that if patients have been educated, they may panic less if this does happen. We tell them not to worry too much about using a bare finger or bare hand to obstruct the blood flow or the bleeding, and that in most cases we can treat infection, but we can't, bleeding to death cannot be treated. We ask them to lift their arm above the level of their heart, and gravity will reduce the blood loss as it has to travel uphill. Call a code if you're in a hospital, call for help or ring 000, and advise patients that when they do call the paramedics, that they tell them that they are a dialysis patient, that they do have a fistula, that they are bleeding, and it is a medical emergency. The next video I'm going to show shows bleeding after the removal of an arterial needle, which we've all seen many times. But if this had been a fistula rupture, the blood loss would be more significant. It does, however, give you an understanding or an indication of how quickly a fistula does bleed and the actions you should take to stop the bleeding. You'll also see the decreased blood loss once the arm is raised higher than the heart and pressure is briefly relieved. This is a poster we use to deliver our fistula health training to our patients, and it informs the patients that a fistula rupture can happen and the 3 steps they needed to take if their fistula did rupture. This photo demonstrates the training that we delivered to our patients, which was very well received. And education was given to patients about the use of mobile phones and how to call 000 with one hand and using a speakerphone. In many cases, the training took a lot longer than we initially thought. This patient uses the steps of applying pressure to her fistula herself, raising her arm to reduce and stop the blood loss post-dialysis. And just quickly, the results, we surveyed our patients post the fistula health education training and they were most pleasing, and much discussion has been generated amongst our patients, and they seem to have taken an overall more of an ownership of their fistula health. And I think a lot of the success of this has been the one-on-one training that the patients received in relation to this. 80% of patients are aware that their fistula could rupture now, and one patient said to me, "I've been dialysing for 9 years and I had no idea that my fistula could burst." About the equivalent could recognise the warning signs of a rupture. 100% of patients knew what to do if their fistula did rupture, if they recognised the signs of a fistula rupture, and 90% of them knew exactly what to do if their fistula did rupture, particularly if they were at home. So looking forward, we want to continue and revise our education that we give to our patients and also to our staff, and I guess that's one thing that's really highlighted some of the education needed for our staff. We need to retest our staff knowledge. We want to make our training resources available and references available to all others to download. We'd like to, in the future, establish a telehealth education tool for our dialysis patients and encourage our patients to the Big DME blog, which looks like this. And I have some business cards here if anyone would like to take some of them back to their units for their patients. It's a fabulous blog which shares experiences from around the world and provides support for haemodialysis patients and their families. To conclude, Diaverum's Fistula Health Training Program delivers 3 key messages. Could your fistula rupture? Yes, it can happen and it can be fatal. Be fistula fussy. If there's one thing you remember from this presentation today, be fistula fussy. Know how to avoid a fistula rupture by recognising the warning signs. Know what to do if your fistula does rupture. So I want you to all to pretend that you're bleeding, and we are going to do the actions. So your fistula's bleeding, you apply pressure, you raise your arm, and you call for help. Just about. These simple steps will hopefully lead to a worldwide application and the potential to save many lives. Thank you.